Welcome to Grand Rounds. Thank you for showing up virtually. I will confess that I was anticipating this being in person up until last evening, so I will kind of adjust the talk for sort of that online presentation. CME code is on this slide, and I think it's on the last slide as well, so you might take a picture and get it done. Thanks for being here. This talk is on neurosarcoidosis. Here's sort of the main points. And then as far as disclosures, I have no financial disclosures. My next disclosure is this is a talk meant for being in person for discussion, but it just is hard on a virtual platform. Each of these bullet points could in and of itself be a 1-hour talk. And we're consolidating this down to 45 minutes or so. So forgive me for that, which is going to make it a little bit of the streamlined presentation. The next thing is this would be meant for a symposium. Each of these topics is actually super interesting. I will hopefully make it interesting, hit the points that I think are curious about neurosarcoidosis, both the science and the clinical application of that. You are welcome to interrupt with questions. I just find the Zoom platform a little bit difficult for discussion. So I'll kind of get started, march along, and then let's do it. So neurosarcoidosis. First of all, it's actually fairly difficult to definitively diagnose. And we're going to cover this a little bit later, but just starting there. In 2018, 19, 20, a group of neurologists got together to really define neurosarcoidosis because, as you'll see later, it is extremely under-researched. Given the incidence, we don't know that much about it. So in defining neurosarcoidosis, we have definite, probable, and possible. It is entirely tissue-based, and we'll cover this a little bit later, but whether you diagnose it definitely is entirely tissue-based. So what is sarcoidosis? Again, I anticipate everybody can, or expect everybody to be able to read, but it's a multi-system, non-infectious disorder, histopathologically characterized by granulomas. And that's what we're looking for on tissue, is the presence of granulomas in a lack of infectious or malignancy situation. It is global. That third bullet, I think, is important. So in the United States, the total incidence is 10 to 20 per 100,000. There is a strong difference between the white population and the black population. Significantly much more higher representation within the black population. And culturally, I think this can explain why the research is so scarce going back based on the history of our Western civilization and culture. I do think there's a movement to understand this disease significantly better, but I think we have a history to account for why we don't understand sarcoidosis more than we do, even where we are in 2020, 2022. There is a genetic component to it, but given that the immune system is responding to organic or inorganic, outside antigens, pollution, socioeconomic status, work does seem to correlate to incidence of disease within socioeconomically disadvantaged population and the black population itself. Here's just some bullets that I think are important. I'll hit something that's a little bit more interesting. Systemic sarcoidosis is the most common. That's involvement of the lung, the lymph tissue, skin, eyes. Neurosarcoidosis is really quite rare, and especially it's rare isolated from disease involving the lung, lymph system, skin, and ocular system. Systemically, so those last two bullets, sarcoidosis is chronic in only about 25% of patients. So it can be a monophasic illness. It can be the immune system responding to an external threat using this granulomatous strategy to take care of that external threat, and then causing some monophasic illness, damage to the tissue in which that threat presented itself, but then going back into a balanced immune system. As far as that disease state recurring systemically is only in about 25% of cases. The last bullet. Neurosarcoidosis, once it's declared itself within the nervous system, brain, spinal cord, pituitary axis, is much more chronic, so 50%, if not more. This leads to curious questions, and again, I'm going to kind of keep marching and maybe address this later. But once the immune system has declared the ability to form these pathological granulomas outside of the tissue that responds directly with the external environment, the disease has really shown itself to most likely be a chronic or relapsing recurrent disease. Then the question of, does this affect treatment? I think it strongly affects our duration of treatment or continuation. So here's where it's going to get a little sciencey. I have more disclosures. I am not an immunologist. I go to immunology talks and I follow for about 5 or 10 minutes, and then it gets really complicated and it goes above my head. I also think we are learning so much about the immune system in all of these diseases that we just don't understand the nuance of how these cells communicate with each other, how they decide what the strategy is. But we are going to talk about some big words and at least try to wrap our brains around what is happening physiologically, and then secondarily, what is happening pathophysiologically. So granuloma is a combination of the innate immune system combined with the adaptive immune system. The way I think about it is an external threat stimulates monocytes, macrophages, dendritic cells, etc. Those cells see the threat coming in from the external environment, and they ask for help. It circulates back to the lymph system. The lymph system then sees what's going on, has a conversation using all of these complicated proteins, immunotransmitters, and then decides the best way to approach the external threat. From the lymph system, it goes back to where the threat is, typically the lung, and then decides how to address this problem. That last bullet seems to be important in the reading, kind of coming up to speed on some more recent research. CD4 cells seem instrumental in the granuloma's formation, and then the cell called Th17 cells are newly identified as probably one of the main cell lines that is helping decide whether to continue having a strong immune response or whether to back off and consider the threat neutralized. Again, somewhat more of the same. What is a granuloma? I will point out the parentheses on some of the cytokines that have been instrumental in granuloma formation. So interferon, TNF alpha, and especially that because it translates into one of our treatments we will address later. IL-12, IL-18, also IL-6 is getting more attention, but this is what we know at this point. The immune system from the lymph tissues decides to create these multinucleated giant cells, these granulomatous, as a strategy to protect self from the external stimulus or external threat. So pathology. Why are we talking about a disease when it seems like an appropriate immune system response? Well, once the immune system tries to keep an external threat out or remove an external threat, there's friendly fire. So the growth of this tissue, the highly inflammatory nature of this tissue does damage to the surrounding organ, the surrounding tissue, and also somewhat downstream, which we'll maybe address when we talk about the nervous system pathology. So again, sarcoidosis can affect any organ, but it's most common where the individual interacts with the external environment. Again, lungs, eyes, skin. Secondarily, any other organ system can be involved. Once pathological granulomatous disease declares itself within the central nervous system, it is a much bigger problem, in my opinion, because that's not a direct interaction with the external environment. I don't have a slide on this, but we're going to talk a lot about the meninges. In some of our neuroimmunological diseases, there's a new idea that the meninges actually can serve as some sort of a lymph system. It is controversial, not well known. But when I think about that in other neurological diseases, and then think about my patients with neurosarcoidosis, kind of makes sense to me that the meninges is a gathering place for T cells, B cells, lots of inflammatory cells, as they either protect the nervous system or attack an external threat. And since sarcoidosis really seems to be an outside-in phenomenon when it involves the brain, pituitary spinal cord, I see it making sense that this meningeal, highly inflammatory response that becomes granulomatous is really what's causing disease in neurosarcoidosis. You can see the title of this slide. This is actually, it reads very well. This is where I disclose that I am not an immunologist. You are welcome to read this if you want. I'll leave it up for a minute. It just gives more detail and supports the same premise on why we get granulomatous disease. So I think I've paused reasonably long enough. A few points to make. These cytokines, TNF alpha, are going to come up later. And then I think some of the research is headed to really understanding the Th17 cell in this disease process. All right, thank you for bearing with me on the worst slide in history. This gives just sort of a visual idea of what exactly is happening. I probably won't summarize that much, just to keep the talk moving. But again, you get an outside threat, a proper immune system response, where a granulomatous process is decided as the best line of defense. If it's monophasic, it self-resolves once that threat is done away with. If it becomes a cyclical inflammatory process, the granulomata persists and actually grows physically and in its inflammatory nature, which then is what causes disruption to the organ involved, and that causes pathology or disease. I believe I transition here. Are there any questions that people want to answer over or want to ask over the Zoom platform? I'll probably keep moving. These couple of slides are just in case we have immunologists doing research in the audience to at least validate that there is research happening headed toward understanding sarcoidosis much better than we did a decade ago. And as I mentioned, some of these molecules come up as treatment sites for sarcoidosis. Here's just a picture of a granuloma. Again, tissue. This is how we confirm sarcoidosis as the cause of disease. I am not a pathologist, so I defer to them, but we're looking for certain staining, the multinucleated cells, as you see in the top right. So I think I've said this multiple times. This just gives a breakdown of how I think sarcoidosis becomes pathological. I like analogies. In the interest of time, I'll probably skip it. You can come to your own conclusion. I think trench warfare in World War I probably has some analogies to what is happening in sarcoidosis. A threat, you draw a line in the sand, you create these intense lines of defense, but within the lines of defense, there's substantial damage to the areas around the line of defense. Humans have a history of thinking outside threats need to be obliterated. War isn't the most fun thing in the world, so I try to come up with better analogies for patients. Home alone, a kid is left by himself and has an external threat, trying to take care of it to not allow the outside intruder in. The best way to handle it is once the threat is over, you go back to normal. The pathology happens when you keep this high level of alertness, high level of defense mechanism that then damages the surrounding tissue where the granulomatas are formed. All right, transitioning. So back to the real world, which pathology is a real world, so forgive me if we got pathologists here. When to truly consider neurosarcoidosis? As we all know, it's the great mimic. It can go on any differential, and with legitimacy, we can think about it in any neurological situation. However, that's not always valid. Yes, we do a history. Yes, we do exam. We pride ourselves on localization of where the problem is. However, when sarcoidosis really becomes a true, definite possibility is, in my world, based on imaging. So imaging is everything as we truly decide if sarcoidosis is likely the problem. So in neurosarcoidosis, there's really four major, most common presentations, and you see them listed there: cranial neuropathies, meningitis, chronic meningitis, brain parenchymal involvement, and I'll translate that or transition that into pituitary hypothalamic involvement, and then spinal cord. The way I think about sarcoidosis, I actually can think about the similar or same pathophysiology which causes each of these presentations. So although they're the most common, I think it fits with how I view sarcoidosis becoming pathological. If the meninges or the peel tissue is a site of inflammation and then thickening, so that packing meninges, it makes sense that the smallest fibers of these, the cranial nerves, exiting the brain, coming out through the subarachnoid space through the meninges, to me it makes sense that those are going to be most at risk for damage. If the meninges is truly the site of some sort of immune system response, lymphoid aggregation, it makes sense that chronic meningitis is the outcome of sarcoidosis. On the brain parenchyma, let's just go down to the pituitary hypothalamic region. As far as percent-wise speaking, there's a lot of surrounding tissue, meningeal tissue around that structure. Again, for me, it kind of makes sense that this all fits together. Spinal cord, what I see most commonly is sort of an outside-in phenomenon of spinal cord injury from sarcoidosis. It's almost this coating in the peel tissue, this subarachnoid tissue, growth and inflammation that then, from the outside in, damages the spinal cord. I do have a slide or two on the peripheral nervous system. That's not really what I'm emphasizing here, but it also is affected in neurosarcoidosis. So to separate these out a little bit, here's some percentages on how common cranial neuropathy is in neurosarcoidosis. And yes, this definitely shows itself in the clinical practice. I think it's from two different pathologies, as you can see on the left. One, I've kind of explained that as the meninges thickens, these nerves are at risk for direct compression. But secondarily, just like the trench warfare idea, if there is an immune response or a line in the sand with high defenses, the surrounding land, the surrounding farms, the surrounding humans are subsequently damaged. So as that inflammatory activity happens, cells are coming in to cause damage to be available. You get direct extension damage of the cranial nerves. That last bullet also is true, but that requires much more intraparenchymal inflammation. I didn't know those were going to click up one at a time. Meningeal involvement, again, being super common. This is just some images as well, and I have some later. Most commonly, this is a subacute to chronic meningitis, headache, with or without fever. Imaging is going to look like meningitis, and then you come to your differential diagnosis. On the MRIs, the top line is the presentation pathology. The second line is response to treatment. And they are all T1 with contrast, but you can see that the contrast is getting in much more deeply than it belongs. I can't see it with the slide there. It just looks like meningitis. So leptomeningeal inflammatory granulomatous disease. The last bullet is clinically true, clinically valid in my experience, that it has a predilection for the base of the skull, and that naturally translates into, I don't have it, I have it later. That naturally translates into pituitary hypothalamic involvement. So moving on, parenchymal abnormalities. This is a picture of a case that would have to be biopsied. This is hard to differentiate between a malignancy, a lymphoma, probably not Mets, but this is where we're going to for sure want tissue in order to come to a conclusion. Again, in my practice, in my experience, this is rare where you get truly mass-like looking intraparenchymal abnormalities. It definitely seems to affect pituitary hypophysis. Spinal cord. Again, you have images there. Actually, I point out some things on images just to get inflammation within the spinal cord, but the enhancement pattern, if you can see my cursor on the far right picture, I think of the enhancement pattern being kind of an outside-in phenomenon. Peel or subarachnoid enhancing tissue, then with intraparenchymal damage due to the the inflammatory component. I think in my practice, I have most of my patients, I think, have actually spinal cord involvement. This is what I have seen most commonly. Once it declares itself in the spinal cord, it seems like it is a chronic, almost forever type of disease. I'm going to go back one slide. So just a point I would like to make, and I have a lot of images, back to when you clinically suspect neurosarcoidosis. So the case, the history of the exam has to fit with localization, obviously then with the MRI findings supporting what you localized at onset. The enhancement pattern is key to suggesting granulomatous disease, is key to suggesting neurosarcoidosis. It's often from the outside in, almost like a sugar coating on the spinal cord or a sugar coating on the base of the brain. Sometimes we don't biopsy these. In fact, I would say most often we don't because it's such high risk. It's high concern for damage to these cranial nerves, spinal cord, brainstem. So sometimes we are left following without a definite diagnosis. When my brain is clued into this being neurosarcoidosis is when there's persistent enhancement over 1 month, 3 months, 6 months. So sometimes these patients aren't so clinically sick to warrant the treatments that we'll talk about later. Sometimes it's good to follow over time to see how the disease declares itself. Persistent enhancement of the same tissue clues me in to this being sarcoidosis. I don't have a slide devoted to that, but as far as in my clinical practice, when after 1 month, 3 months, 6 months, I will buy into this being possible neurosarcoidosis. It is the presence of persistent enhancement, kind of that outside in process of the brain, the pituitary, and the spinal cord. Peripheral nervous system is involved. It can be sensory, length-dependent sensory motor neuropathy. I would say more often it's actually more of a vasculitic picture, mononeuritis multiplex. Myopathy, I've actually never seen. We biopsy people for myopathy. I've never seen a sarcoid myopathy patient. I'll emphasize this again, but tissue is how we make this a definite diagnosis. Paraneurosarcoidosis, I'll be brief with. That bottom one, brain fog, again, people don't feel well. It's thought to be just, again, the immune system circulating highly inflammatory cytokines that probably feeds back onto the fatigue and MS ideas that I presented at previous grand rounds, but that's not necessarily a direct invasion of granulomatous disease. All right, here's another little bit of a transition. So real world, when do you suspect neurosarcoidosis and what do you do about it? MRI is essential. When the MRI has characteristics leading to a suspicion of sarcoid, really your differential is infection, malignancy, so those have to be thoroughly addressed. It's going to use CSF, CT chest, abdomen, pelvis. PET scans are difficult to get to, but you're really wanting to rule out, the best of our abilities, infection and malignancy. And then last slide is what we do, tissue. You try to get to a definitive pathological diagnosis. This is where I want to plug our neuro-oncology program. So they have a great program here. The best part of the program that I see is the Multidisciplinary conference. Our neurosurgeons or pathologists, neuroradiology, oncology, radiation oncology. Seems like a team with a lot of experience and a lot of thought and care. I think they've gotten used to me reaching out to help me with cases. It's actually one of my favorite parts of the job. I kind of wish if I was a neuro-oncologist at times. So they have accepted some of these hard cases when I know we're probably not going to biopsy because it's so high risk. But what they do in the multidisciplinary conference, putting their minds together in a really efficient amount of time, has supported me in my neurosarcoidosis practice because these are tough patients and sometimes we're not going to get a tissue diagnosis. So I want to plug their program a little bit while I'm here. Secondarily, sometimes it's my responsibility to pull the trigger on some potentially very toxic treatments And it's nice to have had their input on the risk to reward of biopsying brain tissue. And I appreciate their help in a lot of these tough cases. Okay, these slides are not terribly interesting, but they are there. So as I mentioned, a team of neurologists came up with diagnostic criteria for neurosarcoidosis. I will reference our lack of research on multiple sclerosis for, I think, not so appealing reasons given the history of our country. These diagnostic criteria objectively outlined it so that we can better research the cause and then treatments of neurosarcoidosis. So it's really divided into definite, probable, and possible. That is entirely based on pathology. Definite would be granulomatous disease in the central nervous system or in the nervous system. Probable is definite granulomatous disease outside of the nervous system, so lymph node, lung, kidney, skin, with suspicion of the nervous system involvement being sarcoidosis. And then possible neurosarcoidosis is a case that sure looks the heck like neurosarcoidosis, but it's in too dangerous of a site to biopsy. Or honestly, sometimes these biopsies, these pathology results come back somewhat inconclusive, inflammatory. And then whether good or bad, it's my responsibility to take the patient along and decide on risk to benefit of some of our treatments. I think we're doing fairly well on time. These are just cases of mine. Again, in person it'd be a little different, but I'm just going to sort of quickly point out a few things. So hopefully this is interesting on some level, and I can't see my cursor. So this is a young guy that came in with new onset headache and fever. We have the flare on my left and the T1 contrast on my right. The left temporal region, medial temporal region looks swollen, looks inflamed, and you see intraparenchymal enhancement, but I think more clearly you see this nodular leptomeningeal enhancement. You can see it around the midbrain, around that left temporal region. Come over to the right side as well, and you see increased contrast. This is actually the same patient, just a higher cut, to show that it's not just limited to the skull base. And these are more intraparenchymal, but you can imagine the meninges goes down deep inside these sulci. So there's pretty widespread, appearing to be inflammatory activity throughout the brain with a predilection for the skull base. Workup would be appropriate for infectious meningitis. And then this patient had systemic lymphadenopathy, and biopsy came back consistent with granulomatous disease, sarcoidosis. Here's actually a different patient, and really I could kind of describe it the same way. These are both T1 with contrast, and using the image on our right, contrast is just getting in places it doesn't typically go, doesn't typically belong. This can be subtle sometimes. This looks like diffuse leptomeningeal enhancement. And again, had evidence of systemic lymphadenopathy, biopsy consistent with sarcoidosis. But since we didn't biopsy the brain, this is probable rather than definite neurosarcoidosis. Again, in my practice, I feel like the spinal cord is overrepresented compared to some of the statistics that I saw. The image on the left is a T2 stir sequence. The image on the right, nope, I'm sorry, I got them flip-flopped. The image on the left is a T1 with contrast. The image on the right is a T2 weighted or stir sequence, and it's a little bit grainy. But what you can see, emphasizing the T1 contrast, is multiple areas not directly connected. And in my opinion, that outside in enhancement pattern, or the word that comes up a lot is nodular enhancement pattern, kind of diffusely throughout the spinal cord. Workup, again, has kind of been addressed. This needs a workup for everything, including infection, malignancy, and a systemic evaluation for lymphadenopathy sarcoid. Again, this patient had outside of the brain and spinal cord biopsy consistent with sarcoidosis. Again, just another patient kind of pointing out more of the same. This is subtle. I actually do kind of appreciate radiology's arrows not totally getting in the way. These are both T1 with contrast. The way I picture this or think of this is, again, that enhancement pattern involving the outside tissues, the pia, the meninges, being granulomatous, being inflamed, and then having that outside in inflammatory damage. It is more subtle, so the one on the left, you kind of have to look closely, and of course we would be diligent in our review of the MRI, but kind of this diffuse pial or meningeal enhancement pattern all around the skull base and the spinal cord. And with it being probable, again, same idea of having outside of the central nervous system. Pathology shown to be sarcoidosis. This is a possible neurosarcoidosis. This patient had actually a left cerebral peduncle abnormality that had some enhancement. I couldn't find a really good image, preparing probably too quickly, but then had this higher up abnormality. Left side is a T2 flare, right side is a T1 with contrast. We considered biopsy of this. We have elected for treatment, and clinically she has done well, but I actually have no tissue. There's no evidence of systemic involvement of any disease, PET scan included. So she would be considered a possible neurosarcoidosis. Obviously, the story is going to be a lot bigger than that. And she's had an excellent response to steroids, incomplete response initially to Cellcept, currently on infliximab. And we will talk about treatments shortly. Here's another possible neurosarcoidosis. On the left is a T2 flare, on the right is a T1 with contrast. This patient presented with headache and really visual deficits, but she also had a contralateral dyskinesia, so facial arm dyskinesia. It was a little bit odd. And this one I really appreciate Dr. Williams looking at multiple times with me on what would the yield be of biopsy. And this goes back a little bit earlier in my time here where I still have tissue. I used to be very reluctant to diagnose neurosarcoidosis without tissue. This is probably that first case where I had to do my best and just call it what it is. He helped me think through this, that yes, we can do a biopsy of this area. What would the yield be? How likely are we to get a size enough chunk to clearly identify granulomatous disease? Either a needle biopsy, very reluctant to do an open biopsy. So this is the case that he helped me march along through and kind of taught me a lot on. Sometimes you just have to pull the trigger in some of these possible disease states. She also didn't do well on methotrexate. She is currently doing well on rituximab, actually. Because we have hopefully lots of neurosurgeons here, we really need their help for pituitary abnormalities. I actually think I lean on neurosurgery both in my previous private practice and currently. Things around the pituitary, we kind of need to involve our neurosurgery colleagues. This case, a stella enlargement with dense enhancement, squishing the pituitary one direction. This actually goes anteriorly, involves the chiasm. This is an interesting case because I held back neurosurgery from an invasive procedure, whether good or bad. He had widespread lymphadenopathy. And my thought was, why wouldn't we biopsy in the chest? This doesn't look particularly like a malignancy. He had widespread lymphadenopathy, kind of held off on a brain procedure, although looking back, I don't know what I should have done differently. Held off on a pituitary procedure, eventually got lung biopsy, clearly sarcoidosis. He has responded very, very well to treatment. The reason I questioned what I did in this case is he was lost to follow-up for longer than I wished. We clearly found evidence of systemic disease, fell off the radar a little bit, and he did have downstream neuroendocrine problems that have not been resolvable. If I get another case like this, I don't know how I will handle it differently, other than really advocating to maybe do the procedure while we have the patient under our watch versus home without patient follow-up. Here's a case after diagnosis. So if you remember earlier, we talked about intraparenchymal abnormality. I actually find this to be super rare because I definitely see that meningeal outside in situation with sarcoidosis. This young man had really aggressive mass-like looking thing, bifrontal regions, crossing midline. Initial thought was glioma. And then with the initial tissue, this is tuberculosis or a fungal infection. Took a whole lot of effort. We actually didn't diagnose it here. Eventually coming to the conclusion of this being neurosarcoidosis. It's been extremely difficult to treat. He's had lots of complications. It didn't look like what I have seen typically with meningeal involvement, skull-base involvement, just a really aggressive mass-like process that turned out to be sarcoidosis. Again, another case, because I think imaging is everything, so forgive me if it's kind of droning on a little bit. This is another neat case. I show lots of our students and residents in clinic. These are all from the same time. So left to right, these are all T1 with contrast. This mass seems to be, or this area, which at this point you'd say it's a mass, seems to be extraaxial, meningeal based, densely enhancing. Thought was headed toward biopsy and neurosurgery. Long story short, history revealed that prior she had been diagnosed with pulmonary sarcoidosis. So the decision was hold off on a neurosurgery procedure, treat with steroids. Steroids definitely improved her symptoms, definitely improved the mass. She then failed one disease-modifying therapy, and currently she's on infliximab. And these are just a before and after, just to show what we can do sometimes with treatment. I don't have the best cut on the left, but that's kind of an extraaxial, meningeal-based enhancing mass compared with the right side that looks a lot better. She was spared a neurosurgery procedure because of a good history and then tracking down that initial pathology and finding that it was in fact sarcoidosis. So she's probable because we did not biopsy this area. Okay, I think that's the last of my cases. Hopefully that was decent at best. This will be another time if you have an immediate question, but we have a little ways to go also. Okay, real world stuff. I would say these next two slides are imperfect, but we check ACE levels, or I'm asked a lot of times about interpretation of ACE levels. Long story short, I'm not a big fan of interpreting ACE levels. I will say in my reading that ACE has a high specificity. So if ACE is normal in the serum, it does suggest that the patient does not have a systemic granulomatous disease. There does not seem to be significant positive predictive value in a serum ACE level. So you have to use it as a data point that you decide how to interpret. CSF ACE just consistently does not have significant validity in interpretation for disease process. I will claim I'm, again, not always the expert, so I'm open to additional questions or discussion outside of this situation because I am always trying to help people interpret ACE levels, and I kind of wish they didn't exist. CSF is an important test in suspected neurosarcoidosis. So what is expected? First of all, the reason we're getting CSF really, in my opinion, is mostly to rule out infection, whether it's an acute meningitis or a chronic meningitis. I think it's also to help rule out malignancy, as far as a leptomeningeal carcinomatosis. But then you want to anticipate, what am I trying to find? What do I expect to find if it's sarcoidosis? We're typically expecting a lymphocytic pleocytosis. The range of how high the white cell count is massive, so it doesn't seem to be definitively super high or definitively moderately elevated. We expect to see protein elevated because this seems to be an inflammatory process. Oligoclonal bands are not terribly helpful. Again, it's present in a fair number of infections, a fair number of inflammatory diseases. But again, if you see oligoclonal bands, it at least clues you into this being an active immunological process. I think the research is headed toward more specific testing. This is all mostly research rather than clinically available. But you see there elevated CSF IL-6, IL-10, or a flip-flop pattern of the CD4-CD8 ratio. Quickly, the CD4-CD8 ratio is extremely helpful in lymph pulmonary biopsies or bronch biopsies. When I read the research, they're trying to apply that to what we see in the CSF. It's definitely imperfect at this point, but trying to provide the systemic sarcoidosis data to what we're trying to find in the CSF. And I do think this is actively being researched, and I think helpful information will be coming during our careers. Transition to treatment. So, number one, there are no FDA-approved treatments for neurosarcoidosis. I have to go out of my way again to mention that this affects the Black population significantly more than the white population. I think we can draw conclusions from that based on the history of our country. This has not been studied well enough to even get to FDA-approved medications. So some of us out here are doing our best with limited support sometimes. Steroids. The mainstay of treatment is steroids. You want to see steroid responsiveness. And then just how we handle lots of neurological diseases, once you declare that patient as being steroid responsive and needing longer-term steroids, then you're going to transition to a steroid-sparing agent. So I would just lump this in with how my brain thinks about myasthenia gravis or CIDP, although in those diseases we are getting more FDA-approved treatments. But neurosarcoidosis should respond to steroids. And then in my opinion, since this is a bad disease, very quickly you're starting a steroid-sparing agent. I might just skip that for now. That last bullet. So there are some comparison studies on methotrexate versus mycophenolate mofetil showing that methotrexate has somewhat of a higher efficacy, higher risk. These are pretty small trials, but this does actually make it into the insurance algorithms in telling us exactly what to use as our treatments. So just like in other neurological diseases, steroid-sparing agents include methotrexate, mycophenolate, azathioprine. I would say pick your favorite, go for it, just know what you're doing and what you need to monitor. I think more interestingly, if you combine the first part of this talk on what forms a granuloma, what keeps the granulomatous process going, therefore leads to healthy tissue destruction, TNF-alpha seems to be a consistent marker of communication between these cells to kind of keep the defenses super active, super inflammatory. Infliximab, adalimumab have been used for quite a while, so we have a long history of using these medications, primarily in the dermatology, rheumatology world. There are multiple case reports now, prospective studies showing that infliximab is very effective in neurosarcoidosis. I think. So in my practice, I have motivation to get my patients on infliximab as soon as possible. It's been kind of cool to watch these large mass-like meningeal-based structures or even perispinal cord inflammation. It's almost like the tissue melts away on infliximab. I think that makes sense back to the pathophysiology or the pathology that these large multinucleated granulomas or cells create this mass, they create this swelling. That swelling is what damages the tissue, whether it's the cranial nerve, whether it's the pituitary, whether it's the spinal cord getting squished. And if we can stop that swelling, it's almost like a tumor, then we can get the tissue back to functioning normally. It's been fun to see some, again, melting away of some sarcoid tissue with infliximab. So I might be jaded a little bit, but this is my preferred medication in sarcoidosis. These are just additional maybes. Cytoxan, it's got to be, again, Cytoxan, rituximab is pretty safe. We don't know for sure that it works. Radiation would have a role, I think, in that mass-like process. Surgery at this point would be to help get to a definitive diagnosis, rarely needing debulking. Then future treatments. So this is actually basically the end of the talk. So if you go back to what immunologists are figuring out about what forms a granuloma, and then what keeps it going, causing it to either enlarge physically or recruit in more inflammation, causing damage to the surrounding tissue, there's lots of cytokines that are being expressed. The JAK-STAT pathway seems to be super active and involved. Well, we now have a treatment, but I'm going to say the word of it, that interrupts that pathway. There are case reports in refractory neurosarcoid of this working well, but we need more studies. Tocilizumab, which is an IL-6 inhibitor that we are comfortable using for other neurological diseases, also might have a role in stopping that granulomatous formation, stopping the inflammatory process, and sparing healthy tissue. And then I added rapamycin on there, both from my previous experience and if we have child neurologists, hopefully people have already recognized the mTOR pathway. We have a medication that works on the mTOR pathway. I've used it in a couple kids with tuberous sclerosis. In my previous practice, I was a little bit outside of my comfort zone, but I would say this immunology world is already a lot of times outside of my comfort zone. But this is a drug I'm comfortable with. I prescribed it for kids, and it really has a potential direct impact on stopping that granulomatous formation. So I'm actually done with my slide. Here's going to be a little bit of a plug. I have a friend, Andrina Johnson, and she is an aspiring actress and filmmaker from Louisville. And she actually last year, a couple years ago, did a documentary, and it was shown at an independent films festival. She has some funding, is in touch with the Bernie Mac Foundation, and she's a big proponent of we got to figure out what is going on. She actually sent me a little clip of her movie. I tried to play it for the pre-people on, and it just doesn't have enough volume. But you'd be welcome to check this out. The website's down there, purpledocumentary.com. Trying to get the word out on this disease process, trying to increase awareness, therefore increasing funding. The Bernie Mac Foundation, I kind of think of as 20 years behind the Michael J. Fox Foundation. So think how much money Michael J. Fox has raised in his career. Bernie Mac is at least a well-known comedian. Unfortunately, he lost his life, but his spouse has now taken it on to kind of fund sarcoidosis awareness and sarcoidosis research. That's the end of my talk. There's a CME code again. I actually want to thank Dr. Sid at Vanderbilt. I've bounced sarcoid questions off of him many times over the years. We saw each other at a conference this summer, and I just kind of had my list of questions ready to go. He gave a sarcoidosis talk at AAN last year, kind of at least participated in me getting this talk moving in a positive direction. Thanks for being here virtually. I think virtual is imperfect, but I appreciate your attention if you gave me attention. Thank you.
Can I ask a question?
I think you can ask a question.
Yeah, all right. So the hallmark of sarcoidosis is the non-caseating granuloma. Beryllium also does this, and berylliosis. So now that we know so much more about these immune mediators, is there some commonality in the response of beryllium and sarcoid that would explain the similarity?
I think it's a good question. I don't have enough knowledge to really answer it with authority. I do feel like the granulomatous formation is actually a proper immunological response to certain external threats. Like that's how the immune system decides this is the best way to take care of this external threat. I don't know if beryllium seems to trigger some of those same pathways, but I think that the granuloma formation has validity, and this is a proper response to an external threat. The pathology just comes with not shutting that down. Those would be my only thoughts. I appreciate the question.
Dr. Robertson, I have a question. This is Zermina. How often do you see neuropsych manifestations in neurosarcoidosis?
Yeah, that's a good question. So how often do you see neuropsychological manifestations or complications?
Yeah.
I mean,
I feel like I see them a lot.
Yeah, I'd basically say much of the time. I'd say it matches some of our other inflammatory CNS diseases. And whether it's a direct effect of the disease itself or the nature of chronic illness, we don't know. There are ideas that the body, the immune system being in sort of a constant pro-inflammatory state, does change brain chemistry, leading to higher incidences of neuropsychological or neuropsychiatric symptoms in these diseases. And that's actually also true for systemic non-CNS diseases, lupus, RA. But to your point, yeah, a lot of our patients have difficulty with the neuropsychological sides of life.
Thank you, David, for your comprehensive presentation. You won't be surprised for my suggestion that the microbiota could be involved in this because of their close relationship to immunity. And there are preliminary studies that show the organisms that live in our lungs may have a contribution to sarcoidosis. This is important because it suggests ways to diminish inflammation. So a high-fiber diet will create more regulatory lymphocytes, which are tolerance-inducing. And there is one trial listed on clinicaltrials.gov for diet in sarcoidosis. And in regard to the meningeal contribution that you excellently presented, one aspect of that which hasn't been considered is the meninges are in correspondence on a molecular level with the bone marrow in the skull. And before I read about this, which is only in the last 6 months, I never really thought about bone marrow being present in the skull, but apparently it is, and it could contribute to immune processes in the brain. And my question is, what happened to the Kveim test, KVEIM? I remember that being discussed in the 1980s. Is it obsolete?
Yeah, so to your question, the AVIME study, I know nothing about it. And I did some prep for this talk also, and I didn't come across it. So it's something I could maybe look into. And then I like your thoughts on, global microbiota. And I think you'd be happy to know that when I have patients ask about diet, the only definitive I give them is high fiber. After that, we just talk about, we don't know for sure, but I push high fiber thanks to you.
Very good. The other part of high fiber diet is not eating meat because meat has no fiber.
Yes, and then I have to recognize my patient population. But yeah, sometimes I appreciate it.
David, that was a really nice talk. I'm curious, as a surgeon amongst other surgeons here, how often do you think we're getting a tissue biopsy done on patients like this, like out of your whole proportion of patients that you're managing and taking care of?
Yeah, good question. And again, I appreciate your help around here. So I think it's become less common because of the chronic meningitis. I feel like biopsy is, and from our conversations, kind of a shot in the dark to try to prove something we don't know for sure. Those with truly mass-like presentations, it's handfuls. It's a rare disease, and then a very rare situation within a rare disease. I'm seeing much more spinal cord involvement come in, and I'm so reluctant to biopsy cord. In fact, I just don't know when it's super useful. So, and many, and so far if not most of these patients do have pulmonary or mediastinal involvement, which is so much more amenable to a procedure. So it is extremely rare. I'm sure we'll come across cases as we do this together, but I'd be reluctant to biopsy unless it's definitively a mass-like appearance.
David, this is Martin Brown. Can you hear me?
I can, yep.
So it's not actually from your talk anyway, and thank you. That was really enlightening. And that's a really challenging topic. I can see wanting to put that lecture off longer and longer because it's so daunting, but that was great. So it seems to be a disease of the meninges rather than like the oligodendrocytes. And if it is affecting the meninges, a spinal cord biopsy isn't really necessary as much as a meningeal biopsy, which seems a little, I'm not going to say it's easy, but it seems a little less dangerous.
Yes, I sort of agree and I sort of disagree. And again, we have surgeons here, and I'll reference Dr. Williams also. Sometimes I'm like, dude, just get tissue, help me out, because I'm the one that has to pull the trigger on this toxic medication. And the counter is that, dude, I'm the one that has to open up their XYZ and go in with my instruments. Like there's risk with both approaches.
I might comment.
And then there's,
I think the challenge with some of the peel biopsy of the spinal cord is that typically these kinds of lesions are relatively thin. There's not a lot of it's not as if you have a granulomatous mass in many cases. So it's hard to go in there, as much as that approach is difficult, once you're there to get enough tissue that you feel confident that you're getting something that is usable by the pathologist, and at the same time not doing some damage to the cord is a bit of a challenge. I had a case, I was curious, I had a case not long ago of a granulomatous reaction to an intrathecal pump. And I'm curious, which is a very different topic a little bit, but I'm curious whether some of the same immunologic agents that are being used for sarcoid might have been used for this patient. Does that seem appropriate, or is it more specific to the sarcoid process, do you think?
Yeah, no, so I think, again, not to be simple as a neurologist, but when we don't know for sure what it is, steroids. And if it seems like it's going to be a longer term thing, it's what's the steroid sparing agent that I as a clinician have comfort with that might attack the target. Methotrexate, mycophenolate, azathioprine are non-specific. And then if we know the pathophysiology or the true process, then you can get more specific with a JAK-STAT, infliximab. And I might piggyback on one more thing. Sometimes whether or not to get tissue or even CSF depends on yield. Like, what is the likelihood of seeing exactly what you want to see? And then let's say you don't get exactly what you want to see. Is that really going to change management? I think that way sometimes with multiple sclerosis and a spinal tap. If it's MS, the history of the exam, the MRI looks like it. Does CSF add anything just to check off, oh, you have oligoclonal bands? Because then if the CSF comes back negative, if the CSF comes back not showing what you expected, is that actually going to change your approach to the patient? So if we try to get a peel biopsy or a meningeal biopsy and it comes back inconclusive, well, is that actually going to change what I do as a clinician? If my thought is, no, I'm still going to use steroids, mycophenolate, infliximab, then I think the risk of a procedure isn't worth pushing our neurosurgeons to intervene on that patient.
Hello.
Hey, Dr. Snap, Next Research. How you doing?
I'm fine. Good morning.
Morning. Really appreciate you making.
You might wrap it up with Dr. Friedman.
Just wanted to catch up on Alzheimer's here and kind of get your expectations.
Rob, can you turn off your microphone?
I want to give you a little heads up. So
Lilia, can you turn off Rob's microphone? Okay. One more question about the biopsy. It is in like giant cell arteritis, we're doing steroids, not waiting for the biopsy. Will steroids affect the biopsy, the yield? Will it be any different, or should we just go ahead and treat and then try and make a diagnosis later?
Yeah, also a good question. I think it depends what the tissue looks like. If the question is this a mass malignancy or sarcoid, there's time to get tissue. If you know for sure we need tissue when cancer is really differential, I would wait and get tissue.
Yeah. Okay. Great.
So it depends on what the differential is, I guess.
Yeah, understood. Yeah. Thank you. Oh,
And
well,
then to piggyback,
would the steroids affect, would it change the sarcoid tissue anyway?
yep, so I was going to answer that too. Eventually, yes, but whether that's 24 hours, 72 hours, or 2 weeks, I have no idea.
Okay.
But again, the whole goal of steroids is to shrink these mass-like things.
Yeah, I
So
guess it would
eventually, yes, the tissue should change, but whether it's what the time to change, I really don't know. And I don't know that science is out there.
All right. Well, thanks again. This was great. Very informative.
I appreciate it. Thanks for being here.
Thanks, David.